Hi, everyone. My name is Dana Howard. My pronouns are she, her, hers, and I am a bioethicist and philosopher in the Center for Bioethics in the College of Medicine and also in the philosophy department. We are so excited, the Center for Ethics and Human Values, to have this conversation about research ethics panel on the ethics of research with sexual and gender minorities. We're grateful for the Office of Research for financial support and also for the Center for Bioethics in the College of Public Health for letting us do this. So in 2016, the NIH designated gender and sexual minorities an official health disparity population. This is a welcome change that increases research attention and possible funding opportunities to work with LGBTQI communities. However, more research opportunities does not necessarily translate to better research. This panel will discuss the distinctive challenges of research concerning sexual and gender minorities, including the risk of research fatigue, prioritization of research, stigma, trust, community empowerment, and whatever it is that you all want to talk about today. So we are delighted to have a terrific panel. We are first going to hear from Florence Ashley, pronouns they, them, who is a trans feminine jurist and bioethicist. They're currently a doctoral student at the University of Toronto Faculty of Law and Joint Center for Bioethics. Florence publishes widely on law and bioethics as they appear in Trans Lives, with work appearing in journals such as the Journal of Medical Ethics, the University of Toronto Law Journal, and Bioethics. We also are really excited to have Julia Applegate, the director of Equitas Health Institute at Equitas Health, where she leads LGBTQ health education and research efforts to improve the health and wellness of LGBTQ plus people. Her pronouns are she, her, and she works also to promote medically underserved communities across Ohio and beyond. Julia holds a Master's of Arts in Women's Sexuality and Gender Studies and a Master's of Public Health degree from the University of Ohio State. The Ohio State University. That's our institution from here. So after Florence will present their work, Julia will also present sort of her work and her role as director of Equitas Health Institute. And then we have Ohio State's very own Julianna Nemeth, who's assistant professor in the College of Public Health. Julianna is an intervention scientist dedicated to conducting the scientific work needed to improve health and reduce disparities for those impacted by violence in the context of trauma, most notably with women and children exposed to domestic violence and homelessness. Julianna is also the co-founder of the Ohio Alliance to End Sexual Violence. Welcome, Julianna. I am so excited to dig in. So just for the audience to let you know what the nature of the session is going to look like, there is a Q&A at the bottom of your screen. Please start typing away questions whenever they come to your mind throughout. I'm going to try and spend as much time as possible the last 20 minutes to just field questions from the audience. There's also live transcripting going on, so you could press CC and you could get it closed captioned, so that's available. So to no further ado, I'm excited to have Florence present first.
Okay, let me start my timer so I don't go too much over. So, hi, I'm Florence. This is Darla. Darla is my research assistant and loves to breathe fire on people who do a bad job doing research with trans communities. So let you be warned, you have to listen because otherwise Darla's going to come for you. So that's the first point I wanted to say. The overall message I want you to take home is that doing sensitive research with queer and trans communities and doing quality research with, and here I'm talking scientific quality, those are not in opposition. On the contrary, they're inextricably intertwined points because, I mean, the clearest example I can give you, if you're doing research and I'm filling a survey and I read, stuff about what is your real sex or your biological sex and using words like transsexualism and stuff like that, I'm closing the window and you're not going to get my response. And that's the response of a lot of trans people. Like I'm on like gazillion Facebook groups where research gets shared with trans communities. And whenever that happens, that something is shared and there's some, like problematic language, you'll see in the comments, people are like, I started answering and then I saw this and then just like gave up. And so you're actually gonna run into trouble with the scientific validity of your research if you're not really integrating community perspectives in your research. And there's also important to know that science is a collective endeavor. So your mistakes, and I don't want to put the stakes too high, but to an extent, like mistakes are being done from not properly including trans people and trans people's perspectives in doing research is going to actually hurt others' research and also involve a cost on communities because, well, for one, if there's no research about a certain topic, for a lot of policymakers, it might as well not exist. So you really need data on phenomena to get money, to convince policymakers that something is a problem, that something needs to be done. And as someone who, sits at a very weird transdisciplinary junction between so I do a bit of research, empirical research and stuff like that. I do a little bit of bioethics, I do a bit of law, I do a little bit of gender studies and trans studies. I really see it like when I'm engaging with policymakers. Tomorrow I'm giving a talk to the Senate of Canada and teaching them about conversion therapy, and much of what my contribution is going to be like, hey, look, we have this data that says this is bad, that says we need to do something about this. So you really need that data to redress ongoing injustices. But the problem is through phenomena like research fatigue, not only are you impacting the quality of your own research, but you're impacting the research of others, because what happens is research fatigue, so I explained it, it's a little bit like a sort of occupational burnout, but for being a research participant. So you kind of get burnt out of participating in studies. It's worsened by studies that are not necessarily very sensitive to the realities of trans people, that are poorly adapted and responsive to their needs. But our research you participate in takes a certain amount of emotional and psychological toll, and to different degrees. And the goal is to really minimize that amount of toll, because if participants get burnt out, and especially in trans communities are very small communities, you're not going to be able to power your study in the future. Other peoples are going to struggle to recruit. And, recruitment of trans communities is actually quite difficult. Unless you're, a powerhouse that's already well connected and trusted by trans communities. And I think, in Canada, we have examples like the Transpulse team, which is led by Greta Bauer, but as like the primary investigator, but a lot of co-PIs are trans. It's very community grounded. There are a lot of focus groups that are really empowered to shape the research. In fact, the focus groups get invited to be co-authors on a lot of publications. It's very deeply intertwined with activists and trans communities. Unless you're in that very particular situation, you're gonna struggle to get enough research participants in your study. So we really need to get this kind of collective work going, where we do high quality research. It really minimizes the negative impacts on future research endeavors, because otherwise it's going to be bad for your research, because you need it to be powered enough if you're going to publish stuff. But on top of it, there's a harm to trans communities, because better future research is not going to have enough participants, or is going to struggle with keeping the participants if it's longitudinal research and things like that. So it's really important for both the research community and the researched community that people do a really good job. And now I really want to go through kind of a really quick list of do's and don'ts with trans people. The first thing I keep seeing is what we call a one-step approach to identifying trans people in surveys. One-step approach is you use one question to identify trans participants. What that usually looks like is, I mean, there's two ways it can look like. One is, are you trans? But the bigger one that I see more often is, what is your gender? And then you'll have male, female, transgender female, other. Bad idea, don't do that. Why? Well, because first principle, trans people, trans male are male. If you're a trans man, you're a man. So what you're doing there in separating them out is you're marginalizing trans people in a kind of like conceptual way. And what happens with that is, well, sensitivity issue, right? People drop out, but also people will just straight up not, they're not going to answer the way you expect. Like trans people will just be like, I don't like that. I'm going to answer, male. I'm going to answer female. Screw that. And in fact, it's still a problem. It's still a problem if you do, cis male, cis female, trans female. Without, it's not as bad, but generally it's been shown that what we call the two-step method is better. And I'm gonna explain what that is. So the two-step method is to have two questions. First one, what is your gender identity? Male, female, non-binary. If it's local research, you're gonna want to include culturally specific identities that are found predominantly in the locale. So in, where I'm from, where I live, you're going to include usually two-spirit people, and then you're going to include like gender not listed here, and then specify with a write-in. And so you do that for the first one. And then the second one is, what is the sex that you were assigned at birth? And then you can, add a specification. This is usually the one that's on your original birth certificate. That's how you identify trans people. Why that's important? Well, first, you're going to get way better response rates and accuracy doing that. It allows you to do subgroup analysis for non-binary people, which is important, right? Like, I'm non-binary, I'm male at birth, but putting me in the same basket as a transmasculine non-binary person isn't going to capture very different experiences, right? And in fact, right now we're moving towards having a three-step approach that includes gender expression, which can also be very important. So we're really noticing the importance of gender expression in capturing different lived experiences for trans people. Now, that's if you're doing research for trans, like specific to trans people, and you really need to identify trans people. That's what you're going to do. If you don't need that information, default to gender identity. Just include one question about gender identity. You don't need to ask about sex assigned at birth if you're not interested in doing a subgroup analysis with trans people. So just don't ask. And generally that's going to be the best way to do the research. Now, there's always the question of controls, and I see that all the time. You're going to have a research on trans men on testosterone, and it's going to be matched with cisgender women controls. And well, for one, a lot of people find that kind of offensive because it's defaulting to treating trans men as like kind of women. But also importantly, it's not giving you interesting information. It's not giving you clinically relevant information in like 95% of cases. An example I can give is one that really struck to mind is blood profiles of trans men. Often studies be like, oh, they really have heightened hemoglobin and hematocrit rates in their blood, and then that causes a sort of like policymakers are like, ooh, like testosterone is dangerous, but really all it's doing is raising it to what is a relatively typical rate for cis men. And if it's the same range as cis men, it's not concerning, right? So, so you need to kind of like focus on what is clinically concerning, and oftentimes what is clinically concerning is going to be done by gender matched controls, not sex assigned at birth matched controls. There's a little asterisk there. Oftentimes it's going to be useful to do both controls for a bunch of different reasons, right? Like sometimes, like if you're studying marginalization, you want to kind of like situate the marginalization. And so you're going to want to do both controls. And then there's the very tiny exception that I call, which I think philosophically falls under the idea of both controls, which is, for instance, if you're studying pregnancy. If you're studying pregnancy, you might want to do both controls, but testing against cisgender men is not going to return anything, so you just don't do it. So this is a case of like, so you would do both, but you know there's not going to be any clinically relevant outcome in one of the groups, so you just scrap the group. And that's like the very narrow situation where you're going to want to do like only one control that is matched based on sex assigned birth. In other scenarios, you're going to want gender match controls, or you're going to want both cis women and cis men controls. And really that should be guided not by some theoretical intuition about, you know, what's interesting data. It should be really kind of like intentional and based on clinical and social relevance. What is the information we need for policy making? What is the information we need for good clinical practice? Because comparing trans men to cis women in the abstract is not really helpful. Like there has to be a point, because we're talking about, you know, like research that causes research fatigue. We're talking about really marginalized communities that need a lot of research to help out. So if you're wasting resources doing, you know, high theory kind of stuff and stuff that's not going to have any practical impact, I would personally say don't. I know some people are going to disagree, but I would generally think we're really not at a point where you know, trans people and trans communities are well enough in broader society to just do research that has no credible, tangible impact on their lives. Now, adding to that, use community appropriate language. I pointed that out earlier, you know, when I started about biological sex, about, you know, words like transsexualism. Make sure you're using language that trans communities themselves use. Biological sex is generally not liked because it implies that, for instance, trans women are biologically male, which, you know, a lot of people would contest, citing back to Butler about how sex was always already socially constructed and is co-constituted with gender. I won't bore you with the theory, but the point being, you know, words like sex, words like biological sex are actually gender terms in everyday language, and we need to take that into consideration. We can't just abstract from that and pull out some sort of idealized non-transphobic category of biological sex. We can't, you know, we can't pull back from the history of terms, and we need to use accurate language. So using terms like sex assigned at birth and things like that, which place the emphasis on the process of social categorization of bodies, which, you know, like, yeah, like for instance, I have no, you know, I would never call myself biological male, but I have no issue saying, well, yeah, I was male assigned at birth. That was, you know, when Rafiki, the doctor, was like, ta-da, Simba, it's a boy, you know, and then my mom was like, and my dad was like, you know, like that happened, you know, I'm not going to be like that didn't happen. Yes, I know everybody loves my Lion King analogies. It was my favorite movie when I was a kid. So, you know, use the language and also be receptive to critiques and things like that. I mean, one of the best example I can give was so I was doing a commentary in the American Journal of Bioethics of Maura Priest's paper on the right to transition for trans youth without parental approval. And I just emailed her being like, hey, like natal sex, not a great term and stuff like that. And she just answered back like, oh, I didn't know, I'll change it. You know, and actually we became friends through that interaction. So, you know, it's not the end of the world. We like trans communities understand that like stuff happens. Consulting is just a good way of you know, like flagging all those issues and and getting through them. And no one's going to get offended if you ask. Just be sensitive in the way you ask, and ask, the right persons, and big important thing, do pay participants, do pay organizations you collaborate with. And one thing that people don't think about, help organizations who want to conduct research on their own get research approval. So that's a real problem, is community organizations oftentimes don't have access to an institutional review board, are not able to go through that process. And if you want to really be an ally or an accomplice, try to figure out ways of promoting their own research agenda on their own in parallel to your own. So have it really be a kind of like mutual support. They're helping you with your research, but sometimes they want to publish papers in scientific journals too, and they can't because they can't get research, they can't get ethics approval. Help them get ethics approval. Give them, work with your research ethics board to create a funnel approval that's less costly for them to do that. Paying participants is tough. Think about how you want to do it. Don't do like one gift card for every 100 participants. People just find that insulting. And I know it's a big debate. At the very least, if your participants are moving, you have to compensate adequately for their time, because they're taking time away from their job. They're, traveling, it costs them money. And also from a scientific validity standpoint, you want to include everyone, not just people who have the money and privilege to take time off their day and to come see you and things like that. So there's also just the scientific validity aspect to it. If you compensate, you're going to have a more representative sample. Simple as that. And kind of part of that, foster responsive community-based research. Make sure that you're always intentional and that the research you do actually responds to the needs of trans communities and not what you think their needs are, because, well, oftentimes you're going to be wrong. And, that's fine. We all have different bases of knowledge, but that's what, consultations are for. That's what working with communities actively in community-based organizations is to ensure responsiveness. And that's something that I really emphasize in my work on research fatigue, is we really need to think about responsiveness, because that's what keeps participants coming back. If you ensure that the research actually responds to their need, if you disseminate the results, if the participants are clear as to what are the expected benefits, what are the timelines and all of that, they're going to come back. They're going to do more research with you. If you don't, they might not. So that's kind of a thing. And then also how to fix all of those problems, because, tangibly that might look like a lot. And there's a really cool trick to get to all of those things all at the same time, is center trans researchers and communities and actually give them decisional power. What I often see is like community-based participatory research, but then, just tokenizes communities and doesn't actually listen to their input. If you have, co-primary investigators that are trans, that's going to help. If you give actual decisional power and, an equal voice to community members that are involved in the research, that's going to go a long way towards just like getting participants, because we talk, like trans communities talk, and like researchers actually have reputations. I think a lot of people don't realize that, is like trans communities like know researchers, and we talk, and we'll decide whether we share the call. And a lot of time we won't if we don't like the work that the person has done, or if they're not really engaged with trans communities in a kind of like deep sort of way. And sometimes there are difficulties because funding doesn't want you to have a student who's a co-PI, and oftentimes trans people are students and things like that. But that's the official bureaucratic stuff. That doesn't mean it has to be that way on the ground. Just because someone is listed as a collaborator instead of a co-PI or something like that, doesn't mean you can't give them a central role and central voice in doing the research. So I'm going to kind of close on that and say, there's a lot of things you have to learn to do good work with trans communities, but it's actually going to improve the quality of your research a lot. And when your research is better, not only do you have the gratification of knowing that you're making an impact, but also you're going to make friends in trans communities, which is super cool because trans people are super badass. And also you're probably going to get cited more. Who's getting the most cited right now in trans research? It's not people who do lackluster research that trans communities don't care about. It's people who are really doing the work. I think right now it might be Sari Reisner who's the most cited in trans health, and like trans man at Harvard Chan School of Public Health who does research with other trans people. So yeah, that's it.
Thank you so much, Florence. And now we'll let Julia speak about her work and her experiences.
Oh, thanks so much. Yeah, lots of overlap with what Florence shared. I'll just tell you a little bit about how where I'm sitting is different than where Florence is sitting. So I'm working at a federally qualified health center that centers itself around serving LGBTQ+ communities and other marginalized, medically underserved people. So we do our work very intersectionally. My organization is very much focused on provision of care. I work in a small department. There are 6 of us that work on our mission is really to reduce health disparities in our population through education and research. So we're a very small team, but we do lots of work. For us, partnership is the key to how we do almost everything that we do. We are not we're doing a very small amount of our own original research now. Part of that is just money. We've very little outside funding for the work that we do, very little, like not even $100,000 to employ 6 people and do all the work that we do. So the research that we are doing, that's our own original research, some of it is mine from my Master's of Public Health program that I did to earn my degree. And then that's turned into a larger research project that hopefully will benefit our patients. So we were very much like, I'm very interested in lesbian health. I did a lesbian health needs assessment, polled people in my community. Well, I want to take the results of that and give it to our providers so that we can actually serve the people that live in our community and come to us for care and meet their needs. So I'm very, in the work that I do and that we've done so far as an organization, very much like rubber meets the road. How can what I've learned actually change the care of my friend that I'm encouraging to see my clinicians? The other research that we're involved in is through partnership, several of which are with Ohio State University or Ohio University, with researchers in human ecology or College of Public Health, nursing, folks who have their own research interests, and their population are sexual and gender minorities. That's the population we serve. So we see our role as a way to connect those researchers with the populations that we have relationships with, trusted relationships with. And what we have found to be most successful, and so this is a capacity issue because we don't have internal capacity to write our own grant applications. We don't have our own IRB. We are many years behind something like a Fenway Institute where they've got that stuff built in. So we ask to be written into grants applications with our partners. So consider us subject matter experts and write in a budget to help support our staff so that we can help support you in doing your research. And that for me has been what I have seen to be a really inclusive and ethical way to do that research, because we don't know everything, but we can be that conduit. And because we are trusted in our community by a good portion of sexual and gender minorities in our region, we carry that trust with us, and we really try to honor that. And I don't want to say yes to a research partnership that looks like it's, I don't know, trying to do whatever, where a money grab, or I want to get a lot of publications. It's about building relationships. So we work really hard to build relationships between the researchers and the community being researched. And as an individual who is a sexual and gender minority, I've had a lot of experiences, not enough though, as a research participant. And I would say, the best ones, one of the best ones is the Pride study that I've experienced out of Stanford and University of California, San Francisco. They've developed a tool that looks at longitudinal health of our community. I don't think that they go outside the United States, but they've worked very, very hard to build community advisory boards in all parts of the country. They've partnered with organizations like us in Columbus from all over the United States. They bring us to Stanford to inform their research. They invite us to be part of panels. They pay for our travel. They, as an individual who's also part of that research study, when I'm engaging in some of the surveys are designed with algorithms that allow me to use the language that fits for me. Like if I'm talking about my reproductive health, do I want to say vagina or uterus, or would I rather say whatever language fits for me? And they've got the surveys designed in such a way for the user to move along the survey path and have the language change so that I am seen through my lived experience all the way through. And that's a completely different experience than I had participating in a research study that was done out of Ohio State that was looking for, I think it was measuring stress in marriages. And I looked very closely at the qualifications to be in the research study. And all it said was you had to be married for a certain number of years, and you had to be over a certain age. And so I met all those qualifications. And I was very excited as a lesbian because I'm only legally married 4 years. I've been, in a committed relationship for 19, but because of policy, my marriage didn't count. So I'm very attuned to when it says marriage, do they mean legal marriage or don't they? So I went in as a participant trying to make sure that I wasn't going to register for something I wasn't eligible for. And by everything I could see, I was eligible. I signed up, and then I get an email from the study, somebody in the research saying we're not taking same-sex couples. And I was like, wait, hold on. I read every detail, and there was nothing there that said I was excluded. And they're like, well, we're not researching. This isn't a same-sex couples research study. I'm like, well, it doesn't have to be. You're looking to research people who are married. I'm married. That's a big deal that I could be legally married now in this country. And anyway, I ended up filing a complaint with the internal IRB board, and that study, they had to go back and change their language because, fine, you don't want to research my population, but you need to make sure that you're telling me that on the front end because you've now then re-traumatized me. And sure, I'm fine, I'm in this field, I got over it. But these are the kinds of things that Florence is talking about that make people feel like, why should I? Why should I share? And I'm not someone that comes from that place because I know she's right. In public health practice, I can only go so far by just saying, by a needs assessment, a survey that says these are what 100 people told me. I need data. I need the IRB approved, written up in the peer-reviewed journals to get real money to make real change, like to really improve people's health. And until we have, pathways to make that possible and ethical ways to do that, we just keep going in circles, and it does get exhausting. And, and I'm speaking from somebody who doesn't get exhausted that easily because I'm paid to do this work. I want to do this work. I know how important it is to do this work. And then you've got many people who are not in the space of commitment to doing research that are more likely to just step back. So I've run around a lot of different things now that I've shared. I'll step back now so that Julianna can speak.
So thank you both for sharing, and I feel honored to be on a panel with the two of you. So I come from a public health perspective, but also from having worked in community-based advocacy for years, primarily in the space of sexual assault response and domestic violence response, and also its prevention, so in community-based settings. So I have a real connection really for the health-based needs of survivors. And some of you may or may not know, but violence is one of the ways in which we reify hierarchy and structure that privileges some and not others. And so there's a lot of populations who are targeted for violence, including gender and sexual minorities, at much higher rates than heteronormative or gender normative populations. And so it's important, in the research that I do now, because I have made the research transition, that I recognize within the populations that I'm working with, I allow people, right, to identify themselves. And I consider in the interventions that I'm conducting, do things need to look differently? From a population perspective, kind of a step back to, so I don't go in and say I'm researching gender and sexual minorities. That's not the approach I take. One of the things I do recognize on our population-based surveys, our epidemiologic surveys, meaning that we can generalize our findings back to the population, oftentimes we are not asking questions that allow people to identify themselves in terms of sexual orientation and gender identity. And of the large population-based surveys that we have out there, oftentimes they use the one-step question, if they have anything, that Florence alluded to earlier, as opposed to multiple step questions that allow people to really represent their experience and the data that they're providing. And so I think big picture, we need to advocate on our national surveys that are collecting information about health in general, that we're including questions that allow people to identify both in terms of sexual orientation and gender identity, and even behavior. So not just identity, but in terms of actual sexual behavior. And there's different questions that we can put on different surveys to get to those things. But we're not doing that on most of our population-based epidemiologic surveys. And that's critical for the thing that Julia mentioned, and that is justifying that there's a need for focused research on specific populations for specific kind of health outcomes. And so we need to advocate at that level. When it comes then to intervention research, which is what I do, we know that a lot of our health interventions, if we just assume everyone's the same and we say, hey, this is an evidence-based intervention and I'm just going to put that out there, it actually creates disparities because some people have access to that intervention the way that it's designed and others don't. And so what I really try to do in my research is figure out what are those things that actually have to be addressed differently to allow all populations to access this intervention. And oftentimes the populations that I'm looking at are unstably housed youth and those that have experienced violence. And so it is important in my work to ask people, to allow them to, I think this is really critical, right, in my research, to allow people to identify themselves in terms of gender identity and sexual orientation. And then I have a responsibility, once knowing that, to figure out if the intervention that I'm designing has to be different based on, sexual identity and gender identity, sexual orientation. So, there's a way to look at the data then to figure that out. And so I think just identification is critically important at this first stage. And I really do try to engage in community-based participatory research as well. So I'm oftentimes aligning myself with organizations that serve violence survivors. I've never worked directly with Equitas, but with Bravo before. So Bravo is an organization that's sort of now part of Equitas. But critically important to get feedback from the communities that you're working with. And I think part of that is also just putting surveys and research items in front of people to figure out, is this going to work in this population, in this community, where there actually is great diversity, and really understanding the way that you present that information back into communities. Does this work? From my perspective, those are the things that I would really encourage those that are interested in research, and especially from the public health perspective, to do. We really just don't foundationally have enough data oftentimes. And researchers that come to Ohio State that are interested specifically in sexual and gender minority research, my data set sometimes, I have large enough subpopulations to allow them to use that data for specific purposes. If as researchers, we don't ask these questions, it doesn't give people opportunities to understand how it is that health interventions and outcomes are impacted by gender and sexual minority status. And so we really have to include that in all of our research. So yeah, I think I'll stop there because I do want to leave time for questions, but I'm available at Ohio State, and I'm really open to working with gender and sexual and minority populations that want to do specific research, and opening my data sets to people if they're really interested in doing research in this area. So thanks.
Thank you so much. And let me open this up to Florence or Julia if you want to respond to each other before I start asking questions.
I mean, my only thought I had was like, what about the justice requirement of the Belmont report? Which, I mean, I don't know, was it like 44 C whatever, the federal code provisions that implement the Belmont report in the US? I don't know it as much, but like in Canada, like it's enshrined in our Tri-Council guidelines, and like there's a justice requirement. You can't like unjustly exclude population. So the idea of like, oh, we're not including same-sex couple, like, okay, why? Like, do you have a good reason for that? Because if you don't, then that's not okay. Like, you need reasons to actually exclude people too. So it's not just like having the language, but also like I don't know, it raises a red flag for me, because I'm like, why are you not including, like, I see that with trans people all the time, like, oh, we're not including trans people. And I'm like, why? Like, why? And they're like, oh, like oftentimes they make up some bullshit excuse about how like trans people are supposedly different and stuff like that. I'm like, you have like a million subgroups that are going to be different too, though. Like, you're really singling out, like trans people or queer people for exclusion, when you have a bunch of other situations that are equally, going to complicate your research,
I mean, for me, absolutely. Why is that allowed? But it just is. It seems like that's the practice that, unless you say you are specifically studying lesbians, gay men, SGM, trans, all of the above, then it's just the thought is that you're not studying them, because they don't make the space for us to self-identify. Hey, I want you to know, when I go to the dentist, I want my dentist to know if there's anything unique they should know about me because I'm a lesbian. And you know what? There are things they should know and think about, like, give me the dental dams at the dentist and let me take them home. But, like, don't just do the research on me and my life and my community when you are thinking about me. I should be part of all the research, but that's what Julianna's saying, they don't ask us. So we're invisible.
So let's move to questions right now, if that's okay, because there's starting to roll in some questions. Just a reminder, the Q&A is where to ask questions for the panelists. That's where I'm going to be able to keep track of it. So there's already one question that's out there. I'm going to start with one of the sort of preset questions that I emailed you earlier that is really related to some of these issues. In the comments in the chat, Robin Sendikian said there's a catch-22. You need the data to get the money and you need the money to get the data, right? And so one of the questions, I think a structural question that I would love to hear from all the panelists is just sort of the structural and funding challenges that exist when engaging in socially valuable, like the research that, you know, we want to actually be done. And how can partnerships between academia and organizations like Equitas Health Institute work to overcome these sorts of challenges?
I don't deal with money, so. Although I do get a lot of papers rejected on account of being too specialized, even though the same goddamn like journals are going to publish, you know, papers on like this one gene that's involved in this like super rare disease. And somehow that's not too specialized.
I mean, from the perspective of, you know, wanting to have an impact through doing research, whether it's ours or partnering with other people in their research endeavors, it's just, you all know who do research. It takes a lot of time to do research and it takes a lot of money to do research. And we have neither. We don't have the capacity. I mean, like when I say time, I don't have staff hours to devote to doing research. And when their partnerships are there, the partnerships are truly partners. We are real partners and we're valued for the expertise that we can bring, either because of my staff has it or we can connect to the community. And then there's some money that comes our way, then I get to build a bigger staff. And then that actually helps the researchers because we have more capacity to be better partners. And I mean, I can't even, it's hard for me to even imagine the years it's going to take before we actually have journal articles we're attached to. I'm just, again, thinking like, let's build a program and how can we do that from day to day? It's hard. I mean, community-based organizations are not who the NIH is thinking about when they're putting out funding opportunities. So we're over here saying, okay, OSU, Wright State University, whoever you are, we're here and we would love to be your partners and we'll be good partners, we promise. But that's the way we try to do research.
Answering this question, I think there's a lot of different things going on in my mind, which often is the case. But you know, I think it goes back to the fact that at the federal level, with our population-based epidemiologic studies, we need to be measuring sexual orientation and gender identity, because that's something that none of us can do individually, but it lays the groundwork for why it is that specialized research is needed. So I think there is really this need for advocacy at the level of people who control what questions get put on surveys. So I'll just say that. The other thing that I want to say is for all of those researchers, oftentimes NIH is funding kind of endpoint research in terms of health. And so our larger study might be set up to look at you know, cancer prevention or smoking cessation, you know, in a larger population. In studies like that, it's also very important, right, that we are allowing for all subpopulations to identify, really, because we know our interventions are not going to be as effective, you know, if we don't take into consideration specific context of specific subpopulations. We do need to power our studies to be able to do subpopulation analysis from a research perspective. The other thing I wanted to point out is NIH recently now has released supplementals that you can specifically focus on sexual and gender minority research. So if you have a larger funded study, it's possible that a researcher who's really interested in doing specific research with sexual and gender minority communities can apply, for a supplemental and work under a larger study and really focus on, specific subpopulation analysis. So those are, some of the things that I think about. The other thing that Julia pointed out that I think is critically important, and having worked in community-based work that was totally underfunded for years, right? It is critically important that we partner and pay organizations and participants in this kind of research. It's also important that as we put the findings of the research back into communities, that we are also still partnered in that work. It's not okay, right? The research process is full of, who we research, how we research, the questions we ask, the way that we put the information out there, impacts people. And it's really important that we're working with organizations that serve populations that we're doing research in all steps of the research process. What I can say is I'm not sure we have enough of the vehicle between community organizations that don't have the access to the research infrastructure with Ohio State that does, and so I think part of it is we also need to work on those structures for allowing for that connection. And I think part of it is also just the way we're structured as a university and what gets prioritized. For young faculty members, oftentimes community-based research is not what's valued. In fact, I was sort of told at some point, like, don't do this kind of research in your early career. And I was like, I can't not, because I come from a community-based perspective, and that's where my strength is, right? And so I think it's also, we prioritize different things. We don't necessarily prioritize faculty to do community-based research, especially kind of as they're starting in their careers. So there's some structural things, within the university and what's prioritized that also has to change in order to be effective. I've seen some grants where they didn't allow you, some internal grants at OSU where they didn't allow you to bring in an external partner on some things initially. And I'm like, they need to be there from the beginning. So I think there are, things within the research structure that also have to change.
So Madeline Adelman has asked, I would appreciate hearing viewpoints on research with youth, specifically interested in consent waivers as a universal, presuming risk on behalf of youth, or selective ethics practices, such as youth-driven decision to secure parental or guardian consent. Should we have age-based determination, other factors? Thank you.
I have a lot of feelings about this because I work on youth. I mean, I specifically work on youth consent to medical care. So yeah, I don't like consent waivers. So let me just put that out there. I'm not a big fan of chart reviews, for one. I think chart reviews are often abused by clinicians, just putting information in the chart, surreptitiously, and then going back into it for research to circumvent consent, and that pisses me off. That said, a lot of youth can just consent on their own. It's jurisdiction by jurisdiction legally, so that's hard to make general statements. But in Quebec, where I'm from, there's a hard line at 14. If you're 14, you can just consent to participate in all research that's not posing a very high level of risk. So for most population-based research and for most public health research and all of that stuff, you're going to be fine. And it's also important to always think about, I really like the concept of scaffolding that we find that Kukla has been relying on in their work on consent. And this idea that we can kind of support decision-making capacity in people who, may otherwise be kind of on the line of being able to provide informed consent. So we just need to, researchers need to spend more time doing the informed consent process, making youth understand what are the risks, what are the benefits, what is the goal of this, and really kind of engage them as, you know, as agents and as people with autonomy who are able to make the best decision for themselves as to whether to participate or not. And oftentimes through doing that, they're really going to reach a point where they're able to give, you know, free and enlightened consent. So that's generally what I favor over parental consent. Sometimes you do need parental consent, and that's, you know, when you do need that, I do think that's where you're gonna want to go over consent waivers, unless, you know, very particular situations where you might want a consent waiver, but then, you know, there's the consent assent distinction that often, you know, matters a lot in like pediatric, like clinical pediatrics. And I think there's a place to like import that into research. So have kind of like a consent waiver, but have a substitute assent procedure can in certain cases where like going for parental consent might be dangerous, because we're talking about, you know, trans and queer youth. They might not be out to their parents. There might be a lot of context and stuff like that. So, but you know, really recognizing the degree of agency that youth have through assent to consent process.
Yeah, and I mean, I seek waivers for parental consent in the research that I do with youth. And I think the other thing that's really important is no matter who it is, that they understand that they're consenting or assenting to research and what that is. So there's a long process. Anyone that research with me, it's really important that the participant understands what they're agreeing to, and that there's this conversation about it, not so much what's written on the page. The IRB probably doesn't want me to say that, but you know, sometimes this language gets in the way of really making sure that the person understands what they're, you know, consenting or assenting to. So I do waivers, you know, and I think there is a literature out there that I cite, you know, when I do research, because of the ramifications that what they're disclosing to me could, you know, could come back on them if a parent or guardian were to, you know, were to know or have to consent to allow them to participate in research.
So we are out of time. This is actually a good plug for next month's CARE panel on the ethics of research involving minors. So please, I mean, a lot of these questions are going to be pertinent next month as well. Thank you so much, Florence, Julia, and Juliana, for really opening up a conversation. I really appreciate you being here and your insights. And thank you everyone for joining in.